So here we go. So let me share the screen here. I think it's going to be pretty doggone awesome here. So let's get started here. Again, the presenters is myself, Dr. Gavin, who needs no further introduction. Very bad. The GOAT, as he's been called by many. He served, I guess, on the Obama administration through the First Lady Obama, Michelle, and with diabetes. So he's a policy writer, by the way, guys. And we're very fortunate to have Dr. Gavin on board with us. I know that a lot of people are very jealous of that. I get a lot of interesting calls. People want to know, how did you do that? Say, when God showed you a favor ain't fair. The next person is my good friend, my cardiologist too, Dr. Anthony Lewis, board certified in internal medicine and in cardiology, as well as in I think it's called an interventional cardiology. I think I got that right. In other words, he puts stents in you when you got a problem, all right? So that's me again. I'll move to me very quickly, but I'm board certified in emergency medicine. I did my training in general surgery at the Cleveland Clinic Foundation in Cleveland, Ohio. And I have to say Cleveland, Ohio, because sometimes clinic has like a number of different places now. So I'm only going to associate myself with the Cleveland Clinic Foundation, all right? Then I already mentioned Dr. Gavin. Dr. Gavin is CHP's chief endocrinology, chief chronic disease consultant and curriculum director. So whatever you see come out of my mouth, I pass it by curriculum director, duh. And of course, again, that's Dr. Anthony Lewis, trained at the renowned Mayo Clinic in Rochester, Minnesota, board certified in internal medicine and cardiovascular disease. He is a chief CHP cardiovascular disease specialist. Now, this is the very first skit. Notice his heart attack skit with signs and symptoms. So you guys can rate these if you like.
She's a lovely woman. I adore my wife. She's a lovely girl. Met her back in her early 20s. 40-some years in. Damn, she's still with my crazy butt. Oh, well. But it's been good so far. Hey, never had any problems, no heart attack, no stroke, none of that other crazy stuff going on. I know I read about it and hear about it all the time, but nothing's going on. So, hey, I'm just sitting here today. Oh my God, I feel a little warm. Damn. Am I really sweating? Holy shit. God, oh, a little pressure. That ain't nothing but a little pressure. That's all that is. It's a little pressure. Oh, a little nauseated. I think I'm gonna throw up. Oh, Elizabeth, come and join you, baby. Oh, honey, I think I'm going to the big one in the sky, Lord. Oh, Jesus, help me, Lord. Call 911, please. I know Dr. Reynolds, when I took his course, he said time was muscle. I think it's a heart attack for sure. Please call 911, please.
Okay, so this is an action scenario, case scenario. And I'm sure Brandon, he's had these kind of calls too. And so we have a person going to be giving us a call into the ER. Do I have a paramedic on the line? This is Dr. Reynolds over at the ER hospital here.
Yes, this is paramedic Fred Crusher with Unit 777. We are en route with a 68-year-old black male who developed chest pain 1 hour ago that appears to be getting worse. He is sweating. He complains of nausea and lightheartedness. Is this Dr. Reynolds correct?
Yes, it is. This is Dr. Reynolds. Can I ask you a question here? Can you go ahead and hook this patient up to a 12-lead EKG? I want to take a look at his EKG if you have that availability.
Yes, I just sent it.
Okay, great. Let's see what we got here. Okay, Fred, thank you for transmitting such a beautiful EKG here. The patient looks like it does have what we would call a STEMI, which is an ST segment elevation MI And let me go ahead and see if I can get Doctor that's on call for the STEMI, which is Dr. Lewis. Dr. Lewis, can I get you, sir? Are you there, sir? Fred, first of all, Fred, what is your ETA?
My ETA is about, I'm sorry, about 3 to 4 minutes out.
Okay. And could you give me any vital signs on this patient as you're on your way over?
Yes. The vital signs are they're stable. Patient's vital signs are stable.
Okay.
And his blood pressure is 152 over 90. Pulse rate is 88 and regular, and an oxygen saturation of 94%.
Does the patient have any history of any heart problems in the past?
He has no medication at this time, and as we can see, only thing that we can see is asking for something for pain. I asked the patient if he's on erectile dysfunction medication as well.
By you being a paramedic, I'm really happy to hear that, because that's kind of important for us to know that. If the patient, by the way, Fred, as you know, have taken any of the erectile dysfunction oral type medication, whether it's going to be Viagra, Cialis, or Levitra, if we give them nitro, as you know, Fred, then we'll probably drop that patient completely out of the picture, and he'll probably go into cardiogenic shock because of severe hypotension. So again, let me see if I can reach Dr. Lewis. And Dr. Lewis, if you're available. Dr. Lewis, I have a patient that's coming in. I have already alerted the STEMI lab. He does have some ST elevation called tombstomy in leads 2, 3 in AVF, and some reciprocal changes in leads 1 and ABR. So with your permission, we'd like to go ahead and get the patient ready to go up to the cath lab, as we know time is muscle.
Do we have any idea how long he's been having the chest pain?
If I was told he's been having chest pain for approximately 1 hour.
1 hour. He is en route to the cath lab, to the hospital.
Yes, sir, he is.
I do have a copy of his EKG, and it appears to be an acute inferior infarction. I would get him transported here. I'll be here in the next 20 minutes at the hospital.
That sounds like a plan, doctor. So we'll go ahead and we'll send him over to you. So the patient now has been successfully transferred, got to the hospital. We looked at the patient very briefly. We did some basic laboratory studies, including troponin. However, as you know, any doctor would know that troponins mean absolutely zero when you have a STEMI, right? But we do those things anyways. We get him upstairs. So Dr. Lewis, the patient's groin has been shaved. We did not give the patient any oxygen following the new protocols. We only give patients oxygen when their O2 sats are below 90. His O2 sat right now is 94. O2 sat was not given. He was given a nitro. He did get some pain relief from that, and he's all set to come up. He looks like he's fairly stable at this point. All vital signs are in a very positive direction. So he's yours, and now you have him upstairs in the cath lab. Talk to me.
It needs to be started on heparin, anticoagulant at this time, just to prevent any further clotting.
Okay, that has been administered by the nurse.
Okay. And it would not be a bad idea to give any like ticagrelor, one of those antithrombolytic, antiplatelet drugs at this time would also be in order. And you can ship them to me. We're ready.
Okay, well, he's now on his way up. He should be there in the next minute or so. As we know, the cath lab is not very far from the ED. So he's your patient now. Talk to him. Tell us what you're doing.
Well, he gets in. He gets moved over to the sort of like a gurney. It's not really a gurney, but to the lab table. I feel for the pulse. He has a very strong pulse. His heart rate is a little on the slow slide, which we sometimes see in patients who have inferior infarctions. We're prepared if we need to put in any temporary support system for his heart rhythm if needed. At this point, we have gained access now to the artery, and we're passing the catheter up into his right coronary artery. We're using a TIG catheter, a catheter that will allow us to go to any of the vessels in the arteries that we need to go to, and we're on our way.
Okay, I'm sorry, go ahead, doctor.
We've taking our first picture of the coronary system, and the coronary system shows a complete occlusion of the proximal RCA. At this time, we're going to ask for a wire to cross the stenosis. and then we'll place balloon stent device to go in to provide open passage for adequate oxygenation blood supply to the heart.
Okay. And I guess you were successful, like you said, that the coronary arteries are not, are they open or what?
The RCA will be open momentarily. We will now be inflating to 12 atmospheres, and we normally hold for about 30 seconds. There's about. And we will be coming down with the pressure now, and we're giving the first tests after the stent deployment. The artery is wide open, there's no dissections, and there appears to be reestablishment of flow to the right coronary artery.
That sounds like a successful story to me. So let me ask you a question then, Dr. Lewis. What instructions do you typically give a patient, assuming that now he's ready for discharge and you've seen him throughout the course? What type of instructions would you give the patient?
Well, he first of all absolutely needs to be on the proper medications. I like to use beta blockers. I like to use aspirin, antiplatelet drugs, to send the patients home on, so that they can make sure that there's no further clotting that can occur without adequate medications being provided. So that's what we typically like to get these patients started on, and that's what he will be sent home on.
Okay, and then the instructions for him in terms of his cardiac care moving forward?
Obviously, is multifaceted, including diet, activities, and if he's a smoker, we recommend him not smoking, even cigars. Excuse me, apologize. So we recommend that our patients adhere to a heart-healthy diet. We recommend that they, not in the first week or so, just gradually get back. It's like any other muscle that is injured, requires time to heal. The chance of the arrhythmias occur usually within the first few days and hours after opening of an artery, and the artery may, in fact, even sometimes close down. So we give a window of opportunity to watch the patient carefully, and they're advised on what to look for as they're being discharged.
So it looks like to me, sounds like to me that what you're saying basically is that when they get discharged, they need to follow the instructions to the T, and there are no exceptions for that.
Absolutely. No deviations can be really appreciated at this time.
Great, appreciate that. Now, what I just did, guys, is I want you guys to just appreciate what goes on from the moment the paramedic arrives at the scene, what happens in the emergency department, like what we do, and then what the cardiologist does. And to me, that's very important for you to understand that dynamic that goes on behind the scenes, all right? And everything's set up where we call it door to balloon inflation. And that's gonna be anywhere between 25 and 35 minutes maximum. That means when you hit the door, we already know what's going on. We get you prepped, get you upstairs. Oxygen maybe not, typically not nowadays, because typically the O2 sats are greater than 92 or so they don't get oxygen. Morphine was something, I'm sorry, not morphine. They do get it too, by the way, but nitroglycerin is something that can give life. It can take it away also. So I tell my men, young or older, that if you lie to me about not taking an erectile dysfunctional medication, and we give you nitro, we're gonna be thumping on your chest, you will not make it to the lab. So the nitro dilates, as you know, those coronary vessels, and it gives us time to get you upstairs to see a person like Dr. Lewis. So what we've done, guys, is that what you're seeing on the screen now is called Smart Heart. We have purchased a couple of these units. We'll have them in service as we go through our in-service over the next week or so. So we do our community health fairs. We'll be doing EKGs on approximately 20 patients with each community health fair. We do 22 community health fairs every year. So the math's pretty simple. 20 times, 22. And that's how many EKGs that we'll be doing. These are extremely effective. This is endorsed by the American Heart Association. It's also approved by the American Cardiology. Association. And more importantly, I love this one place. They love this thing. And it's the Mayo Clinic, as well as, which is in Rochester, as well as in Baltimore, Johns Hopkins. So I think that we're going to be on the cutting edge for this. And in the time where healthcare is being taken away, EKGs are extremely sensitive. It's a 12 lead without all those, those wires and everything else going around. I'm sure Brandon may know about this thing called Smart Heart. I'm not sure if hospital is using them yet or not, Brandon, but it's something that people can even buy these at home. And it just pops on. The limb lead goes underneath your armpit. You should be a little moist, a little wet, shall we say. So if you're clammy because you have a heart attack, whatever it is, no problem. And this thing just straps around you. And it really is a beautiful, beautiful device. Dr. Lewis, you have something to say?
No, you're fine. Everything's good.
Okay. Now, this next patient is a skid of someone who has, shall we say, heart failure.
I've noticed over the last 2 or 3 weeks, I've been having a little bit of trouble breathing. And I always tell people, what do you mean by a little bit of trouble breathing? You're a little pregnant? Okay, so you have a little bit of brother. You have trouble breathing, basically. So I've been having that trouble breathing for a while now, like I said, the last 3 or 4 weeks. And I notice I've been getting more and more short of breath when walking. First, I could walk maybe 200 feet. Now I'm down to 25 feet. I get short of breath. And my ankles, both these bad boys are like cankles. They're like really big, okay? And I just can't breathe well. And I notice when I lay flat in the bed, that's why I'm sitting in this chair here, I go to sleep right here. Because when I go to bed, laying back flat, hell, I can't breathe, okay? So I wonder what is going on with me. Again, I'm short of breath, I can't breathe, ankles are swollen, and I cannot walk very far at all without almost passing out. That is called congestive heart failure symptoms. It needs to be checked out, right? That means you need to see a cardiologist. Echocardiogram, which is a special thing to check the structure of your heart, needs to be done. Yeah, EKGs are important too, but an echo in this case is critical to do. Also, salt. A lot of us get congestive heart failure because we have too much salt in our bodies, which I'm sure Dr. Lewis will talk about the salt intake as well as one of the major contributors to congestive heart failure. And of course, there's all other kind of issues too. If you're overweight, you're going to be most prone to have congestive heart failure. If you have any kind of vascular type disease, you're probably going to be more prone to have congestive heart failure. The other thing about congestive heart failure too is that you'll find yourself with a decreased appetite. You'll find yourself, unfortunately, drinking more water than what you should. Because remember, now, you're not getting rid of the water anyways. So the more water you drink, the worse the symptoms really would get. Okay? So that's the story behind congestive heart failure. So it's not a big dramatic thing here, which congestive heart failure, like the other things that I've illustrated to my little sketches, I call it. But this is something that's very serious. Congestive heart failure is extremely serious because we know that once you get diagnosed with congestive heart failure, your chances of surviving 5 years get smaller and smaller. We're talking about maybe 35% of the people that's diagnosed 5 years prior will have died by the time they hit 5 years. So it's a serious disease. It can be treated. They have all kind of great medications out there, and I'm sure that Dr. Lewis can talk about those things. But our job is to make sure that you understand the signs and the symptoms, the early signs and symptoms. That's going to be what? Shortness of breath, difficulty breathing, swelling up of your legs, sometimes all the way up to here, where we press down on it, and there's a big indentation there. We call it pitting edema. Not a good sign, right? So, and again, walking, you'll find you could maybe walk for maybe 150, 200 feet, no problem. But all of a sudden now, over the last couple of weeks, like I said, I can't walk no more than 25, 30 feet. Get short of breath, okay? So that's the takeaway on that. Bing.
I might add that very often people lose sight of the fact, and Dr. Lewis will probably mention this, that whenever you have congestive heart failure, there's an underlying cause that you're going to find. Whether that underlying cause is coronary artery disease, you've had damage to the heart muscle because of problems with heart attacks and ischemia. long-standing uncontrolled blood pressure so that the muscles have just worn out because of the failure to have your blood pressure controlled. Certain valvular problems, so that people have had problems with valves that have needed repair and they didn't get repaired. So it's always important for people to be aware of the fact that there's a driver somewhere that is the causative agent for or a causative event for that underlying congestive heart failure.
Well, people, I'm here at the Ponderosa here at our house here, just enjoying myself. I believe it's September 23rd. I think it's on a Tuesday, amen. And you can see up in the trees that coconuts falling all over the place. I'm just having a good time out here. Having another stogie, of course, and it is what it is, you know what I mean? And I don't know, yeah. What the hell? What the hell going on? My right leg is like, it's going numb on me. My arm, oh shit. Oh Jesus. Oh Lord. I think it's bad. Call 911, please. I think I'm having a stroke. Oh, everything blurry. Everything blurry. Everything blurry. Everything blurry. Help me, Lord. Help me, Lord. Help me, Jesus.
Question about congestive heart failure in women. You know, I guess we hear or we're taught that women, African American women, have a more difficult time with congestive heart failure, and their um, mortality is cut significantly. Morbidity is significant. Can you talk a little bit about that? I have a colleague and a friend who has been diagnosed with congestive heart failure, and I'm just concerned about her care.
Okay. So congestive heart failure is a real monster. It really is, in particular in our community, and not necessarily just women, because it's devastating to both men and women, and the treatment options and modalities are the same. As Dr. Gavin mentioned, there's always a problem that leads to heart failure. Either it is myocardial infarction or damage to the heart, hypertension that precipitates heart failure, arrhythmias, AFib with rapid ventricular response. Any rapid rhythm can destroy the heart. It is alcohol. They're just a whole list of causes of heart failure. The treatment is pretty much the same regardless. What I like to do is make sure we restrict fluids, start cutting back on fluids, and what Dr. Reynolds mentioned, cutting back on salt. Salt can be a real enemy. And then the medicine Entresto. I found great success with Entresto. In the past, we were limited to things like Coreg and hydralazine and isosorbide and those kinds of things. But now our spectrum has increased greatly to things like Entresto. Entresto is a miracle drug. I've taken patients who are on heart transplants lists, given them Entresto, and they've come off. So the treatment is pretty good with the current medications that are available to us, and we can make a big, huge difference. And of course, all the GLP-1s and 2s also are very helpful in this setting of heart failure. And that would eliminate all alcohol. I mean, beer has been pretty much a significant implicator in patients who have heart failure. So you have to be careful of all alcohol once you're diagnosed with heart failure. I would not take alcohol at all if you have a diagnosis of heart failure. You should become a dry county and not allow alcohol in your home or in your presence if you have a diagnosis of heart failure. So, Dr. Dallum, it is no question that women are affected adversely when it comes to heart failure. In fact, the world is, if one of the leading causes of readmission to hospitals today is heart failure.
Can I just add quickly to that, Dr. Lewis, because as you know, one of the settings in which we see heart failure with great frequency is in the setting of diabetes. In fact, the incident rate of heart failure in diabetes is greater than the incident rate of heart attacks. I mean, most of us are scared to death of having heart attacks when we have diabetes. The fact of the matter is you're much more likely to have heart failure.
Wow.
And it's really important to understand that, because now we've seen the emergence of these newer medications that used to be just diabetes medicines. It turns out they had these important effects. You mentioned GLP-1s, but the SGLT2 inhibitors are even more beneficial in the heart failure of diabetes. And now what we found out is that you don't have to have diabetes to get the heart failure benefits from these medications. So our tools are getting better, and that's good news for everybody.
Totally agree with you.
Thank you.
Come on, Houston, let's go, baby. Durant, let's do it, bro. Bring it home. Bring it home to daddy. God, dog. Oh, damn, what's going on? Oh, the back of the head. Oh, he called 911. I think he got something going on with me bad.
No, that, believe it or not, guys, that really was an interesting skit, primarily because subarachnoid hemorrhages do come on suddenly. Some people that have survived it said it's like a jet that went through their head, right? And of course, the actual survivability of having a subarachnoid hemorrhage that's significant it's not very good. And of those that do survive them, they're left with disabilities. And when you get to disabilities that can be so grotesque, then all of a sudden now, what quality of life do you have, right? So it really is important, again, guys, to know what's going on. Now, this is a hemorrhagic stroke. Fortunately, hemorrhagic strokes account for only 15% of all strokes. Most of the strokes, 85% of those strokes, are what we call ischemic strokes, secondary to a clot. And I did not mention when I was talking about the cardiovascular issue, that is with the heart. One of the things we have to be careful of, and I'm glad that we're getting these different EKGs done now, but atrial fib, and I'm sure that Dr. Lewis will attest to the fact that atrial fib is getting to be one of the leading causes of stroke in people that are over 65. Could you comment about that, Dr. Lewis?
Yeah, absolutely right. AFib is a real big player in the stroke environment. It increases the chance of stroke up to 5 times higher than the general population. So when the heart has these irregular rhythms, it allows for clots to form, particularly in what we call one of the appendages in the left atrium. It just doesn't contract. Contraction makes the blood clots less liable. But when that heart becomes like quiet and doesn't move for a little while, the possibility of clot formation can occur. And then when the heart reconvenes in contracting, it can throw blood clots. So atrial fib is now a real big player in the stroke world.
All right, Fred. Well, I'm glad you're here today, man. But, I haven't been feeling that well, to be honest about it, man. I don't know what it is, but it's like my abdominal area is getting to be, I don't know, a problem. Oh, wait. Oh, shit. I feel like something's ripping. Oh, it's tearing me apart inside here, right in here. Oh, Jesus. Oh. Okay, what you just saw me do was go through pretty much what I would expect to see of a patient if I was at their home, or they could be anywhere, actually. And that person is suffering what we call an abdominal aortic aneurysm. You notice I said I had severe pain that came on very suddenly. This sometimes is the first sign and symptom of an aneurysm, right? And I said it was ripping, it was like it was ripping me apart. That's because the blood vessel itself, which is the main vessel, the main artery that brings blood down to the rest of your body, it's called aorta. So when that begins to stretch, then the muscular part, the adventitial part, the outer layer of the artery has nerves. And when those nerves stretch, that causes severe and intense pain. So you notice when I first started, I didn't feel good at all, actually. And all of a sudden, the pain was getting worse. All of a sudden, it was gripping a ripping type sensation. I knew I was really in a serious problem. So if you notice anything like that at all, do not hesitate to go to the emergency department. Yeah, you're not having a heart attack. You're not having some kind of ischemic bowel problem. Most likely you have an aneurysm. And guys, tell you what, black men that are thin, not overweight like me, I'm getting it under control though, but it's usually thin black men that smoke cigarettes. Those are the typical things that lead towards an abdominal aortic aneurysm. And as Dr. Lewis will say and talk to you about cardiovascular disease in itself, talking about those blood vessels, when you smoke a cigarette, one cigarette, you just smoke one, it'll make your blood vessels constrict, which means that your blood pressure will go up. So smoking is definitely no-no, although I'll imitate my little cigar here from time to time. I'll do that because I think it's kind of cool, but it's not really cool to really smoke them. However, I think it's better than a cigarette, right? We're done.
Okay, Dr. Bishop, make comments about that.
Can leave a permanent mark.
Well, obviously, abdominal aortic aneurysm are a big problem in our country, and for all men over 75, if you have a smoking history, you deserve to have an abdominal ultrasound because you're at risk to have an aneurysm. Aneurysms, just for those who may not understand this, an aneurysm is like in the olden days, I hate to say that, but I guess I'm getting old, the inner tube on the tire, the bicycles, how they will pop out on the side, that's what an aneurysm is. And it's a weakened muscle of the arterial wall that becomes weak, and then the artery itself bulges out, and it becomes very vulnerable and susceptible to rupture. So you don't want to smoke, number one. Back in the day, smoking was considered cool. It is not cool. It is the worst thing that you could do yourself. In fact, I'm certain if it came on the market today, it would never be approved because of the damage that it does to the human life. So even cigars, Dr. Reynolds, are not good, bad.
Yes. We're hearing a little bit of rationalization.
No. They are a big no.
Big no.
Exactly.
Dr. Lewis, could I also add here that, we're talking about signs and symptoms. It's very, very important that along the way, people might have gotten earlier signs and symptoms. We talked about cigarette smoking,
Right.
but those same people who end up with things like abdominal aneurysms will very often have had a history of high blood pressure. They will have had risk factors like high levels of cholesterol, especially high levels of LDL cholesterol, low levels of HDL cholesterol. These are people who would have given evidence that, you're just a walking factory of risk factors, even before those vessels start popping out on you. So early signs, early symptoms, even in routine observations in your routine medical care are important as you assess what your risk might be of getting some of these major events.
Oh boy, what a day it's been. Oh Lord, what's going on this groin? Oh Jesus. I'm having a hard time breathing. I can't breathe. I think I'm going down. Oh Lord. Okay, guys, so what you just saw me do was really showing what a pulmonary embolus looks like, a pulmonary embolus. But you notice that I grabbed my groin first, because typically a pulmonary embolus will start either in the calf, but more important, it's going to be in the groin area down through here, right? And then that embolus, which is a blood clot that's in the vein, it travels up through the inferior vena cava, up into the heart. Then the heart pumps it into the pulmonary arteries, okay? Depending on how much of the clot gets into the artery, it's going to determine how bad your symptoms are. So in the emergency department, what we're looking for basically is making sure that you're oxygenated well, because that's important, because what we're talking about now is we're talking about blocking the blood supply to your pulmonary arteries, into your lungs, right, to oxygenate the blood. So this is a problem with oxygenation, not ventilation. You don't need to be on a vent for this. We need to get you where we're getting the blood flowing through your vessel. So the sooner you pick that up, the more important it is. You may not pick it up, but get to the ER, emergency department. If you have any of those kind of symptoms where you start with pain maybe in your leg, goes up to your groin, all of a sudden now you're having shortness of breath. You notice I was breathing fast. You're breathing fast because your body's trying to compensate for not getting enough oxygen that's oxygenated in the blood going through your body. So that's what the deal is with that. So the important thing to remember, guys, is that anytime that you have shortness of breath, you're breathing rapid, you get a little lightheaded, because if you don't have oxygen, you're gonna pass out, which is what you saw me do. You absolutely pass out. You could be on marble, you can be on, it doesn't matter, on the street, it doesn't matter. You could be in a bed, it doesn't matter. What's gonna happen though, you're gonna pass out, right? And that's just the body saying, hey, listen, I'm not getting enough oxygen to the brain. You get some heart discomfort, sometimes chest pain also, because guess what? You're not getting enough oxygen to the heart either. Because again, everything is oxygenated through the lungs. Then it comes back to the left side of the heart. Then the left side of the heart pumps that oxygenated blood out throughout the rest of the body, to your brain, to your heart, of course, to your kidneys, to your liver, throughout the rest of your body. So that's a PE, pulmonary embolus. But it usually starts with a clot somewhere that's distal. The pelvis is a very good spot for that too, as I just showed you that, and the legs can be also. All right? So just pay close attention to your signs and symptoms. And if you got a sign, you got a symptom, get to the emergency department. Don't play doctor yourself.
Dr. Reynolds, I think it's important to add to what you're saying, which is a good slide. But travel, people who have had long trips of traveling, those are some of the things that you want to look out for when you've been on a road trip or you've been flying in an airplane for a long time. Your legs don't move. You should always keep your legs active so you can pump the blood and use muscles to pump blood back to the heart. So these patients tend to have a history of long sitting or immobility or long travel. And one of the other signs is that they can cough up blood. You're spitting up blood. But usually for blood clots, you want to think about swelling in your legs and your calf muscles and tenderness, and then you associate it with shortness of breath, and then you're coughing up blood, sputum that's tinged in blood, and rapid heart rates and shortness of breath all tend to point toward pulmonary embolus.
Glad you mentioned that point, Dr. Lewis, because that is an extremely important point. And that is, I travel quite a bit. I'm 74 years old. A lot of us are certainly well over 60, 65 or so. And it really makes us even more prone to having these events on an aircraft. Remember that the aircraft is pressurized, which is not a good thing for you either, but it has to be pressurized for us to be able to get up in the air to fly. However, they'll tell you, well, you can walk up and down the aisle of let's say a 777, which is a very large jet. That's not get the job done. You can drink as much as you want to drink, but stay hydrated. But for me, I take a little step further than that. And everybody doesn't do it necessarily agree with what I do. When I'm going on a long trip to Europe or somewhere else, then I'll tend to take Eliquis as a precautionary measure for a day before I leave out. And I take that for 2 days when I get back from my trips. And I've never had a problem. Now, I know I mentioned this to Dr. Gavin once before. Dr. Gavin had mentioned about taking an aspirin.
That's certainly something that I try to keep in mind and remind people of. But I also wanted to ask what you think about the use of things like compression hose as an additional tool, especially for people who spend time in air travel and even in long car trips.
Yeah, I'm glad you mentioned that because as the ER doc and maybe Brandon over there at Northwestern, we have taken socks off, not just socks, but we're talking about compression garments off up to the groin area, PEs, right? So, but yeah, it's definitely something that we should always consider wearing. It does seem to put a little compression and therefore moves the blood through the vein a little bit better, and thereby it may decrease the incidence. I think it would decrease for some people the incidence of pulmonary embolus. So this is one that I'm sure is going to irritate Dr. Gavin. So I'm going to be quickly getting into this one.
Just a context to the medical team. when Doc was talking about heart attacks, there was a question, Dr. Lewis, on enlarged hearts.
Okay, what's the specific question they want to ask me about enlarged hearts?
Just trying to understand. My husband had a enlarged heart.
Okay, so enlarged hearts do come from heart failure. They can come from hypertension. Did he have a history of high blood pressure and that kind of thing? And
High
also,
blood pressure.
yeah, and generally he'd had heart attacks in the past. So the heart tends to dilate because of the pressure that it must work against to open the aortic valve and from the arterial side to get blood to go from your head down to your toes. The higher the pressure that the must exercise to open those vessels, it makes the heart less effective. It becomes a big muscle, and then it becomes dilated, and then it becomes damaged and injured. So the heart does not work in an effective way as a pump any longer when things like high blood pressure, myocardial infarctions, things like this tend to damage the heart. Anything that damages the heart can in fact cause the heart to enlarge. An enlarged heart is bad. You, you don't want a big heart. You want to, I know that sounds counterintuitive, but in this case, you don't want a big heart. You want a heart that's normal size, that's effective, that functions with an ejection fraction. And an ejection fraction is simply how much blood the heart pumps out with each squeeze. The normal range is from 50 to around 70%. That's normal. So when the heart squeezes, every time it squeezes, it should push forward 50% of what's in it. If it can do more, that's good too. But the more ineffective and efficient the heart becomes, it gets bigger and bigger, and you're not pumping any blood forward, and that's the sign of heart failure and an ineffective heart.
So
Okay.
usually with the enlarged heart, is it something they could do with that reference to hospital?
Well, enlarged hearts are the biggest problem that we face today in cardiovascular medicine because they're difficult to treat. They are. They're very difficult to manage heart failure. But it's a effort between the patient and his physician. If you're doing the right things like eliminating salt, at least not nearly as much salt as we used to, maintaining your blood pressure, taking your heart medications that tend to want to strengthen the heart, like Entresto, which is a blood pressure pill, and it also restores function to the heart. So this is how you do it. And cutting back on fluid. You don't want to have a lot of fluid when the heart is enlarged. You want to cut the fluid almost in half, if not more, depending on what your particular circumstance is. So it just depends, but it can all be managed more effectively. And you may need to have elevated bed. You may need to have more than one pillow. Those kinds of things in order to elevate the head of the bed so that the heart can get a little help in pushing blood forward.
Okay, thank you.
Yeah, the next slide is going to be, I'm sure that Dr. Gavin will make some comments on this one.
Okay, here I am. I've just been drinking so much water over the last several weeks. I don't know what it is, and then I noticed I've been eating a lot of food. I had dog. And these dill pickles, 3 of them, going through each one. And I even drank the juice from the zesty dill pickles. And I know Dr. Gavin, probably watching this one, would say, Dwight, are you crazy? Showing the people all that, the pickles. Pickles, last thing you should be eating. But that's what I do. But you know what I do though? I do have me some Diet Coke. Okay, the Diet Coke. But guess what else though? With the Diet Coke though, bro, you guys gotta see this. Boy, there's some cheesecake up in here. Gotta have that. And of course, I have to have my pork chops and that kind of thing. And I've been eating so much more lately too. So I've been drinking an awful lot. eating a lot. And my God, I gotta go to the bathroom. Excuse me, Fred, I gotta go. Oh boy. Man, that bladder feels so much better now, I gotta tell you. That's been going on an awful lot. So I know I'm drinking an awful lot. You know, I could actually drink out of a doggone vase. I get so thirsty. I can drink beer, wine, whatever. I'm thirsty as heck, just as long as it's wet. As long as it's wet, I'm good to go with that. And then the food, gotta have me some pork chops and some other things too. Hog mogs, you know, hog mogs, you know what I mean? And I gotta tell you, man, but it's been rough for me because I've been gaining so much doggone weight. I'm feeling sluggish and tired and everything else. I don't know what's going on. So what I just went over really are just the signs and symptoms of someone who has a person that may have diabetes. The classic triad of diabetes is polydipsia, drinking a lot, polyphagia, eating a lot, and polyuria. Those had to break off to the bathroom a lot too. It's a vicious cycle. The more I eat the different things I shouldn't have, the more sugar is spilled into my urine. It goes to the kidneys. Well, water follows the sugar out of the body. So there's a tremendous diuresis, or I should say, peeing effects from your sugar stain in your urine. So in doing that, you become dry. So therefore, there's a drive for me to continue to want to drink something. And trust me, people sometimes do drink water out of a vase. Okay, water out of a vase. They drink that too because they get so thirsty. They got to quench that thirst. So again, those are some of the signs, but the very subtle signs and symptoms of diabetes. The other thing, of course, is you get weak. You'll sometimes have symptoms that seem like it may be a little heart attack going on. You may get a little sweaty. All those things happen. And when it gets really out of control, you can go into what we call DKA.
Okay, Dr. Gavin, you can go ahead and you can do what you got to do. Say what you got to say.
Well, there's so much to be said that I won't even try to say it all, but let's just say it like this, folks. We're talking today about signs and symptoms. And when it comes to diabetes, I want to start with this. Just like our previous discussion on the enlarged heart, you already been through those early steps that have led to that destination. That's why we talk about things like healthier eating, weight control, checks from time to time on in things like our blood community health fairs, checks on your blood pressure and your blood sugar, because you want to make sure that you know if these things are happening early on, so you can start interventions that can interrupt the journey to those destinations. By the time you get to a point where you have the signs and symptoms that you just saw illustrated in Dr. Reynolds' skit, where you have the polys that he talked about, the polydipsia, that is excessive thirst. You just can't drink enough to satisfy that thirst. The polyuria, you just peeing all the time because that fluid that you're drinking is just passing right through you. Why? Because you have such high blood sugars, and we're not like birds. You know, birds don't have bladders, so you can't. They get rid of things like excess glucose in their bloodstreams through the feces. We don't do that. We can't pee crystals. We have to take fluid. We have to take water with whatever we're trying to get rid of. And so that is the cost of having abnormal metabolism in diabetes. And so when you start getting to a point where your blood sugars are high like that, why is that? It's because you don't have enough insulin. Okay, you either have type 1 diabetes where you don't have any insulin at all, or you can have type 2 diabetes where you just don't have enough insulin to do the job. If you don't have enough insulin, that means you can't use your glucose. Your brain can only use glucose as a fuel. Okay, so you get this accumulation of all this glucose. It's not serving your body's energy needs, and so you get confused, you get fatigue, you feel weak, and you feel like you're just not yourself. Those are sort of the classic signs and symptoms of diabetes. In people with type 1 diabetes, if you have such low levels of insulin, very high levels of blood sugar, you actually have to start burning other fuels for energy use in your body. And what is that? You start burning fat. When you start burning fat, you produce a byproduct called fatty acids and ketones. Those are very acidic things. And that's why you call this DKA, diabetic ketoacidosis. It is a very dangerous situation. Blood sugars are high. The pH of the blood is low because it's acidic. The brain is all confused and it's associated with up to a 10 to 15% mortality. But I want to tell you something else. People with type 2 diabetes have an opposite extreme. They have a condition called hyperosmolar hyperketonic non-ketonic coma. They have blood sugars where you don't have enough insulin action. If you have type 2 diabetes and you have an underlying problem, generally it's a heart attack or maybe it's an early cancer or some other form of problem. Their blood sugars rise to a level sometimes as high as 15 to 1800. It's associated with up to 50% mortality. It's even more dangerous than DKA. And that's type 2 diabetes. These people have lost already about 50% of their body's fluids. If you don't get these people on fluid replacement right away, you've almost basically signed their death certificate. So in both instances, type 1 and type 2 diabetes, where you have these extremes, replacement of fluids is absolutely key. But for type 2 in those hyperosmolar coma situations, the fluid replacement is an absolute emergency. In type 1 diabetes, you got to do fluid replacement because the insulin that you give them won't do them any good unless you give them some fluid at the same time. Now, we talked about the destination versus the journey. Part of the destination that you saw in that skit was that absolutely horrific refrigerator. Okay, that huge assortment of high salt containing foods, concentrated sweets and fats. You see, these are the kinds of things that we urge attendance at webinars like these so that you can get the tools that you need to guide your behavior along the journey. Okay, because when you got people that are insisting on walking around with a stogie stuck between their finger and sucking down dill pickles, those are people that we need to shake. We need to shake them sometime. Okay, and you know these people, and they're hard to deal with sometimes, because they say, well, I can drink extra fluid. I can drink a diet coke, like a diet coke is gonna make all the difference in the world. No, that's just not gonna cut it. So what we're trying to do is to set up some guide rails here, some guidelines for more appropriate behavior to avoid those destinations where people are really in very serious trouble now, and they need to have these urgent conditions walked back. Okay, so that's what I would say about signs and symptoms of diabetes in the most classic way. These are classic signs and symptoms. The thing that I would leave you with on this topic is most people are walking around with diabetes for years and they don't know it because it's so subtle. They don't check their blood sugar, and so they don't know that their blood sugar is running routinely in the um, um, high 100s and low 200s. That's not enough to make you pee all the time, but it's certainly enough that over time it does grave damage to your blood vessels and to every organ system in your body. And that's the perfidious part of diabetes. It is a silent, lethal kind of enemy that happens over time. And that's why the only way you can know is, are you at risk? What racial ethnic group are you a member of? Does it run in your family? Is this something that I should be checking on from time to time just to see where I stand? The answer is yes.
We've got an incredible roundtable coming your way here on NFL.
Hey, hey, Doc, do you smell that?
So
Smells like It smells like fingernail polish remover. I think that's you. You got fingernail polish remover on?
Fred, yeah. I think, yeah, it's me breathing fast like this, man. And the breathing it's fast and slows up. It goes, speeds up, it slows down. Fred, I need to go somewhere, man. I have diabetes, man. I'm a diabetic. I'm gonna just tell you the truth, man. And
Oh, wow.
I've not been taking my medication like I'm supposed to.
What?
I be eating all kind of crap, man, all kind of stuff, man. Cheesecake, you just name it, man.
Oh, Lord.
Polish sausage, you know. I've been having ham,
Yeah.
all kind of barbecue stuff, boy. And then Christine cooks some mean, that Italian food, all that creamy stuff. I just love it, man. But right now, man, I tell you, I just give
funny.
anything if I could just feel better, man, because I'm short of breath. I just don't feel good. I don't feel good.
We gotta get
you
you
need to call 911. I need to get to the hospital, man. I know I'm in trouble. 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 One of the things that we just went over, Fred, you noticed that he said he kept smelling fingernail polish remover. That's acetone. And women know what it is because one is a very pungent smell. And when someone is in DK, diabetic ketoacidosis, DKA, that's one of the things that you smell right away. And that's a very pungent smell. I used to walk past a patient's room when I'm in the ED working, the ED, and I can just tell if a patient is in DKA because I can smell that acetone. And I got to tell you, it smells rough. However, my breathing is very consistent with DKA. Breathing fast, slowing down, breathing fast, slowing down. Very, very common. Being also confused is very common. Being weak to the point you're going to pass out is very common. So the best thing to do is get me to the hospital, okay, so I can be treated. DKA is no joke. DKA, you get admitted to the hospital, to the ICU unit, intensive care unit, because it's just that serious. So we have to do a lot of balancing acts in the ED to try to get you out of DKA, but to make sure you stay out of it, you get admitted to the unit, the intensive care unit, where they give you a combination of things that we already started, which is going to be insulin. We're going to give you some fluids, and then we're going to continue to pray that you do well, because this is no joke. Some patients I've had to intubate because they just were working so hard breathing, so they pretty much stop breathing. So you have to intubate them, put them on a vent, and get them through the process. So this is a very serious process, guys. So if you happen to have diabetes, you do not want to meet me by accident or by happenstance. Just meet me in ED with DKA, because if you do, we're going to be for a rough ride with you. We're going to get you through it. All right? Thank you.
Let me just say quickly, DKA, okay, and let's say that's going to be primarily a concern in type 1 diabetes. So not exclusively, but primarily a concern in type 1 diabetes in people who have a history of taking insulin on a regular basis, where they have not taken enough insulin, they've missed their insulin dose, and now they are in a high blood sugar situation, and their blood acid levels are going high. The reason you smell that acetone is because when your body starts burning fat as an alternative. Okay.
Dr. Gavin, will you give us a working definition for DKA?
Okay, diabetic ketoacidosis is that's a condition in which the body of a person with diabetes has an insufficient amount of insulin, which results in now the burning of fat as a major source of fuel. So they have a combination of high blood sugar, high blood acid levels because of the breakdown of that fat, and that's what gives you that acetone smell, and dehydration. They have severe fluid depletion, Pastor Philpott, because they are losing a lot of fluid in order to pee off all of that high blood sugar that they have as a result of not having enough insulin. So DKA is a diabetic emergency that occurs in the face of insulin insufficiency. Okay, and the major treatment immediately, you have to have fluid replacement and insulin, okay, because those are the two things that you have to to correct. You cannot reverse diabetic ketoacidosis unless you have insulin on board that directs that blood glucose to where it needs to go, basically into the cells. And the fluid that's necessary is that fluid has to restore your body's osmotic balance. You know your blood is supposed to be a certain thickness, if you will, and you have to have enough free water in your body so that you can maintain adequate blood flow, because you start getting a lot of fat accumulation, a lot of thick syrupy like blood, you start forming risk for blood clots and a whole lot of other things of this nature. Now, what you were getting, and generally you have to be in the hospital to do that, okay, to get appropriate treatment for DKA. That's a hospitalized protocol.
Oh
Follow
my
me,
God.
sir. Follow me, please.
I don't know, man.
I need to get you in the room.
I didn't eat. I took all that insulin that the doctor asked me to take, and I just didn't know if I can do this.
Right here, sir, right here.
Oh, thank you. Oh,
Lay down,
thank you.
lay down for me.
Oh,
No, please,
oh,
sir.
man.
Please, sir.
Oh, please, where's the doctor at? Oh, Jesus. Oh, don't lay me down. Get me up. I can't breathe.
No, sir.
Oh, I can't breathe. Oh, Jesus.
I need to... Doc, come in here, please, please.
Oh, yeah. Okay, guys, we're here in our clinic here, and this is pretty much like set up like an ER. Actually, we have everything that you'd find in the emergency department, including intubation equipment, so on and so forth. What you just witnessed, though, is a typical patient. Now, they may present differently, but I was having a hypoglycemic moment, right? Hypoglycemia is oftentimes more deadly than hyperglycemia. What that means is that I forgot to take my insulin. I'm sorry, I took my insulin, let's say this morning, but I did not eat. So what happens, your blood sugar drops, right? When your blood sugar drops, you get certain signs and symptoms. One, you're confused. One, you feel like you can't breathe because you really can't breathe well. You may have a little chest pressure or pain. You may even seize. I was seizing it for you a little bit to just show you that hypoglycemia can lead to those things such as seizures. You may have a seizure disorder, but guess what? If you don't have enough glucose circulating through your body, you will most likely seize. And then the other thing again is the sweating. That is very, very common. Sometimes we'll grab the heart because we think it's a heart attack, right? You think it's a seizure. But what's happening is that, guess what? My glucose was around 41. That's less than 41, okay, deciliters per ml. That means that my sugar was very low. And I've seen patients in the ED, by the way, have a blood sugar of like 22. And they're seizing. They look like they're having a heart attack for sure, grabbing their chest, having chest pain, chest discomfort. And the O2 sats are low too, right? So all of these things are very important. These are important signs and symptoms. So I want to let Dr. Gavin, who is the expert here, talk somewhat about hypoglycemia, how important hypoglycemia is. And it is oftentimes more, shall we say, critical, for lack of a better word, than, let's say, hyperglycemia. Now, Dr. Gavin may talk about hyperosmolar hypoglycemic coma, which is a big thing to say, right? But what that means is that your sugar is so high till you begin to go into coma. That means that coma means, you're out of it. You kind of like fall asleep. Either of those cases could end up having you in the intensive care unit, intubated by someone like me in the emergency department, and you'll wake up and, fortunately, hopefully, you're going to do fine. Okay? So I just want to really do that skit. It's a very important skit to do on hypoglycemia. Again, hypoglycemia means that your blood sugar is extremely low. Unless you bring it up, it's a problem. So if you're on insulin, I'm sure Dr. Gavin, he'll talk about this too, but if you're on insulin of any kind, then your doctor should make sure that you get, we call it a glucagon injection pen. It's not like an EpiPen, but this is for when your blood sugar drops, then you can just give yourself an injection. You'll probably wake up. For us here in our emergency clinic here, we would typically give you like dextrose 50, which is D50, and we usually give you about 50 mLs of that, We inject that into your blood vessels. Oh, what happened? You wake right up. Everything's good, right? Or we'll something. The paramedics. I love my EMS people. They have that protocol too, where they'll give you also just injecting into your veins the dextrose 50. And we typically, the EMS system and us in the emergency department, we very rarely use glucagon because typically we go to the source, we get it right into your blood vessel. Glucagon injection is going to be shot into your muscles. Takes a little time for that to work, but it does work, all right? The other thing too is that just as a quick thing to do, and I'm sure that Dr. Gavin, he'll talk about this, is eating something, drinking something, whether it's going to be it looks like the all remedy thing. Fibrillation, people tend to take orange juice, put a little sugar in it, and they kind of like mix it up a little bit. You drink it, and that does work. Okay, but the bottom line is that we got to get sugar into your system ASAP. All right. So again, it's Dr. Reynolds signing out. This is our skit number 9, and if you think it's worthy of an Academy Award, any of these skits, just give me a check on that. All right. Appreciate you guys. Be blessed.
Hypoglycemia, low blood sugar, okay, which can come about as a result of a person, instead of having too little insulin, having too much insulin, okay? This is usually when people have taken their usual insulin, but they didn't eat the right amount of food, or they mistakenly took a dose of insulin that was miscalculated. Well, now you got a different kind of problem, because now, remember, when you have a situation where you have too much insulin that's now driving your blood sugar really low, the first place you're going to find evidence of that is in your brain. Your brain function is going to be diminished, okay? Because now your blood sugar is low, your thought processes are going to be diminished, and you have different levels of hypoglycemia. You have mild hypoglycemia, and that's where you have people who have blood glucose levels that are in the 70s or thereabout, and those people can treat themselves. That's called autonomic symptoms are present. They get shaky, they get sweaty, but they are still conscious enough to treat themselves. They can drink extra fluid, juice.
Follow me, sir. Follow me, please.
Hold on, man.
I need to get you in the room.
I didn't
You have the
eat.
hypoglycemia.
I took all that insulin.
Okay.
So, Professor, Fred, are you showing it? Because I don't see anything.
Okay, I don't think we need it, but because the other thing, because when the worse your level of hypoglycemia, the more important it's going to be for you to get assistance. Mild hypoglycemia, where you can self-treat, people simply need to know what to do. Instruction is important. Moderate hypoglycemia, where now the person still has some of these symptoms. They get fuzziness of the brain, they get blurry vision, they get shakiness, they get tremors, their pulse rate is rapid, they get weak. They can still self-treat. They simply need to know what their circumstances is. It's important for those people to know or have the ability to check their blood sugar, because you need to know how low your blood sugar is so you have an idea of how much treatment you need. Okay, each 5 grams of carbohydrate that you take in is going to raise your blood sugar level up approximately a milligram or a deciliter or so, something like that. Okay, now severe hypoglycemia is where the action is, because here you're talking about people with blood sugars of less than 40. Okay, this is when people need help because they're blacking out, they cannot self-treat, they require assistance from other people. They need to be in a setting where they can get either somebody giving them glucagon or somebody that can help them in a hospital setting, put an IV in so that they can start a glucose infusion, okay? And that's important, because if you have severe hypoglycemia, it is one of the most dangerous situations that you can possibly encounter. We have something called the rule of 15. In severe hypoglycemia, you get 15 grams of simple carbohydrate. That means 1 tablespoonful of honey or 3/4 of a cup of juice or 3 teaspoons full of table sugar, and then you repeat the blood sugar 15 minutes later. Okay, that's why you get 15 grams, and then 15 minutes later, you repeat the blood sugar. You have to have a way of checking the blood sugar. Okay, and then if the level is still not, the blood sugar level is still not up to above a certain threshold, that is to say, if it's still not above 40, then you need to repeat that process. And you do that until the blood sugar is in a safer zone. And these are people that have to be monitored. And once you get them out of that crisis, they need to eat a meal, okay? A full regular meal. That's the only way you can really safely resolve an episode of severe hypoglycemia and avoid the risks that are associated with that. Okay, that for the sake of time, that's as much as I will say on that.
I'm telling everyone here to get your vaccines. It's very important, guys. If you're over 65 years old, yes, you can still get your vaccines, and they are still free. Apparently, the government, the federal government, have decided to go ahead and let everyone get their vaccines as scheduled, without having to get a doctor's appointment to get a prescription from the actual doctor. So feel free to get your vaccines. It's very important to do that. And I've already gotten my vaccines. I got two a couple days ago. I got the influenza vaccine, which is flu vaccine. I got the RSV, that's for respiratory syncytial virus vaccine. I'll be getting my COVID-19 and my pneumococcal vaccine, because I'm due for pneumococcal this year. So that'll all be going on for me for the next couple of days. Does anyone have anything else to say?
I think there's a question in the chat about checking blood sugar in normal numbers. Londa Gray.
Okay, Dr. Gavin.
Yeah, but generally the normal range is 70 to 140. Anything below 70 is considered hypoglycemia. But remember, there's a lot of individuality in these numbers. But if you fall in the range of 70 to 140, you're in what we would consider to be a normal range of blood glucose with some variability around those numbers. And then the other thing that I would say, somebody talked about the problem that what is the problem that you're having if you feel lightheaded, dizzy when you stand up? Well, clearly they may be dealing with a problem of orthostasis, that is fluid shifts that cause a change in blood pressure or the perception of blood pressure. Dr. Lewis, you might want to comment to people like that sometimes they may just need to stand up more slowly, stand up and stand still before walking if they have a history of doing something like that, because you can never be sure that you're not having an arrhythmia of some kind. So you have to be cautious about those things.
No, that's exactly what I would say, what you said.
Then that means I don't have to say anything else. Thank you very much.
Anyone else?
Well, question. Actually, Dr. Gavin and Dr. Lewis, is it okay to just Dr. Gavin brought it up a minute ago, but is it okay to recommend that people use their TED hose? They don't seem to want to use them at all regarding orthostatic hypotension. Is pretty common. It's certainly aggravated by some psychotropic medications. And, certainly in geriatrics, the fall workup is one of the major syndromes that we always had to deal with. People begin falling, we got to figure out why. Is it a mechanical fall? Is it from, we don't necessarily go all the way to Parkinson's disease immediately. Sometimes simple things happen commonly. And very often it's orthostatic changes that, the just aging of the vasculature in the legs. You lose power in your baroreceptors, and it doesn't equilibrate fast enough. So certainly getting up off the side of the bed slowly, sitting up first before you stand, no jumping up out of the bed, and sometimes just using TED hose. I had to fight to get TED hose from the administration in most of the VAs, and it's supposed to be free, for the veterans and certainly for the family, if you happen to be an officer. So, I mean, that's an okay suggestion, right?
It's certainly something that I strongly advocate. It's something
Yes,
that I use
okay.
for me, of course.
Yes.
You know, at my age, I use just about everything. But yeah,
I totally agree. Support stockings and compression stockings are very much in order. And if you can tolerate a few pounds on it, I think that's even better. Because as you get older, as you said, all those things happen. What you just mentioned, the musculature wasting of muscles and the baroreceptors, et cetera, et cetera. So, no, I totally agree.
I also use support hose too. Mine is about 13 to 14 millimeters of mercury in terms of the compression on it. And I seem to be getting along pretty well with that as well.
For obstetrics and gynecology, I have patients who don't like to deal with those stockings. So now, after complications from prostate cancer and the radiation damage side effects, putting on those stockings was a real hassle, added to the issues. So finally, my wife got me some that were less, lower than the 20, 30 millimeters, and it's easier to put them on, take them off. So I like adjusting your dose for obstetrics and gynecology. I know we didn't discuss issues regarding that specifically, but among Black patients, prenatal care, delivery, et cetera, a lot of issues are coming up. And when you have someone prescribing and telling you what you can and cannot prescribe, dealing with Medicaid, et cetera, it gets to be complicated. Just decreasing the amount of pressure, easier to put on, easier to take off, can help. Thank you.
Thanks. Dear God, thank you so much for being our God. Thank you for these doctors, these individuals, dear God, who've given their life and share their gifts with the world and with our community. We thank you for what we've heard, seen, and felt on this day. We pray to God you continue to strengthen our leadership. Thank you for this opportunity to share together. And we pray to God that we take this information, use it for ourselves, share it with our family, friends, coworkers, our church members, so that we can continue to live greater. In Jesus' name we pray. Amen.